This is part 2 of the medical dictation regarding pelvis fracture, medical dictation at 180 words per minute. Ready? Let's begin. Question: what do you mean by the statement that the periosteum was incised and reflected? Answer: that means the periosteum was divided and stripped off so that we could obtain access to the infected bone and remove it. Question: do you mean the periosteum was removed entirely? Answer: oh no. One function of the periosteum is to nourish the bone that is present. Another is to produce new bone. If the periosteum is reflected from a bone and allowed to remain in the body, it will make new bone. That is what was done here. The infected bone was removed and the periosteum was allowed to lie in the wound, and it got busy and did what it was supposed to do. Question: what is the granulated tissue you refer to? A. Granulation is in the formation of small grain-like bodies in the first stage of the healing process. Question: all right, proceed with your description of the operation, doctor. Answer: after the bone was excised, the open wound was packed with Vaseline gauze and sulfathiazole crystals, and dressings were applied. Question: as I understand, the wound was left open and packed with the material you have mentioned. Why was that done? Answer: to permit the wound to heal from the bottom out. Question: what was the patient's progress after this operation? Answer: his post-operative condition required administering of quite a lot of narcotics and soporifics, but the healing was continual and gradual. I saw him again some 2 months later. He was treated by another physician in the interim. Question: what did you find on the subsequent examination, doctor? Answer: the wound had been completely granulated except for a small area of bone which protruded up through the granulated tissue. This was narcotic or dead bone and was about the size of the end of my thumb. I advised that it be removed. Question: how serious was that operation? Answer: it was quite a minor operation. The granulated tissue was stripped off and the protruding portion, together with a small amount of live bone, was chiseled out and discarded. Question: what progress did the patient make after the second operation? Answer: a month later it was found that the wound had not completely epithelialized. There was very little tenderness in the operative area, but there was some complaint of soreness posteriorly. The x-ray showed some roughening of the ilium posteriorly, inasmuch as there was no increase of local heat and no abscess. It was not thought advisable to do further surgery at that time. Question: there was a plastic or skin graft operation later. What was that for? Answer: the granulated tissue finally epithelialized over, that is, the skin grew over the bone, but there was a very thin scar that was adherent to the ilium. Because of the danger of rubbing against the patient's clothes or bumping the scar, it was thought advisable to reset the adherent scar and bring a layer of skin with a fat pad on it over the bone, so that there would be freely movable skin over the bony prominence instead of the thin adherent scar. That was done, and the adherent scar was resected. A second incision was made about 2.5 inches above the first incision and parallel to it. The fat was divided from the underlying tissue in the area between the two incisions, and that strip of skin and fat was pulled down over the naked bone and sutured in place to prevent separation of the lower incision. The upper incision was allowed to remain open and to granulate and epithelialize. Question: what progress was made by the patient then? Answer: the inferior incision, the one that covered the bone, healed very promptly, nicely, and cleanly. The upper incision, which had been left open and allowed to granulate, did so and epithelialized, with the exception of a very small area that is still open. There is very moderate tenderness present now, and the skin is freely movable over the bone. The upper incision is slightly invaginated or drawn back at one point, and there is a small superficial area from which there is a seropurulent discharge. The discharge of serum and pus is caused by the fact that the skin has not completely covered the area, and granulated tissue is exposed, resulting in the discharge from the moist area. Question: in your opinion, doctor, is that discharge from the site of the myelitis? Answer: definitely not. It is above the site of the osteomyelitis. If there were any connection between the discharge of the osteomyelitis, the sinus would be below rather than above the infected area. There is no evidence of active osteomyelitis at all. Question: what do you find the patient's condition to be at this time? Answer, he complains that his entire right leg feels as if it were rotated and turned outward, and he states that he has a tender area at the popliteal fossa of the right leg over the hamstring tendons. He moves his hip well in all directions. There is serious discharge referred to. The lateral crest of the ilium has been displaced internally, and callus formation is abundant but slightly irregular. There is no evidence of detached spicules. He is disabled from doing heavy manual labor and will be for another 3 or 4 months. It may be necessary to reopen the wound and reapproximate the subcutaneous tissues at the point of the serous discharge, since these tissues become granulated and will not heal out. The reason would be this would be a minor procedure that is frequently done, and disability would not be extended by reason of it.